those spines irregular. There will be quite a bit of soft tissue swelling. There'll be a twisting or mechanism of injury. And then often you say, if there's a lot of joint effusion, you see that, you just want to make sure that you do an MR. It depends on what the orthopedic surgeons want. Sometimes they say, actually, no, it will heal on its own, but often they'll say just do an MR to ensure there's no other internal joint derangement. So an MR shows you nicely that it is avulsed from the foot plate of the distal ACL attachment. The ACL fibers still look like they're quite continuous. Sometimes they can look a little bit irregular, mainly because they are no longer taut. Okay, but then just make sure you look for it carefully and correlate it on not just your sagittal but also your coronal. See that you can follow those fibers through the bundles. So avulsion fractures, common injury. And you can also do a CT scan. Often you don't need to if your X-ray can see a displaced fragment, but sometimes if it's undisplaced and very subtle, it can be easily missed unless there was, as I said, a free-floating fragment. So it's very common in boys 18 to 14 years old. And radiographs can identify most avulsion injuries. A small cortical avulsion can be very hard to see, so which is why you MR to look for it, because you are looking for bone marrow edema, and also look for other associated ligamental injuries. You don't have to avulse. You can avulse the insertion. You can also sometimes avulse from the tibial tuberosity and then extending through the physis as well. So many different types of avulsion fractures. So just a graph, or rather a pictorial representation of common sites. There is some overlap with adults as well. So your A and B is your ACL, D and E is your PCL. You've got your LCL, capsular ligaments kind of here. You've got arcuate ligaments, so your Sagon fractures, reverse Sagon, deep meniscal tibial ligaments. You've got your arcuate sign, so part of your posterior lateral corner. You've got your conjoint tendons, so a combination of LCL and biceps tendon insertions. Okay, there's the proximal attachment. Similarly on sagittal, so similar sites. Okay, so these are common sites of avulsion. There is a very nice paper called Pediatric Avulsion Fractures in the Knee. If anyone's interested, you can have a look in that. Okay, next case. Let's go with candidate 4 now, please.
Okay, thank you so much.
Oh, thank you. Well done. Candidate 4.
This is a frontal radiograph of the pelvis with a single view of the right hip.
Yeah.
I'm looking at the bones. There is an avulsion fracture of the left lesser trochanter of the femur. The rest of the bones appear normal.
Okay.
The tissues appear normal.
Okay. If I tell you that the pain's not at the lesser trochanter, but more along the femoral shaft?
There is periosteal reaction seen in the right femur.
Yeah, exactly. Okay, so you're right. Okay, there is periosteal reaction, so it's quite thin. You can almost say, is it lamellated? But then when you look at it on the other one, not so convincing. I would say it's more convincing here. Okay, now then you decide to do a bit more because you're like, the soft tissues are quite okay. I'm not sure the bone density is okay. Let's do more imaging. So you've done more imaging.
This is coronal T1 post-contrast MRI. Then axial T1 and axial T1 fat saturation. I see that in the right femoral shaft, proximal diaphysis, there is a T enhancing area at this region of periosteal reaction. Then there's no cortical break. There's no adjacent soft tissue mass. So this, if the patient has raised inflammatory markers, this could represent osteomyelitis or the central hypointensity could represent osteomyelitis.
Okay, so patients actually systemically well, apart from palpable hip pain. Patient's quite a keen sports person, runs fastest in her school. No, not unwell, no fever, inflammatory markers are okay. Does it change what you're thinking of?
Then it could be a stress reaction.
Okay. Anything else?
Is, no, I can't think.
Okay, so are you quite confident? Are you gonna tell them that's it? We're gonna leave it alone. We're not gonna do anything more, or are you gonna say, I want to do more stuff. You can choose to repeat imaging. You can choose to do another scan, a different modality. What will you do next?
I would like to do a CT scan of this.
Yep.
So on this axial and coronal CT scan, I see that there is a diffuse cortical thickening seen in this proximal femoral diaphysis, having a bone within bone type of appearance.
Mm-hmm.
So this could represent congenital conditions like osteopetrosis or infections.
Would osteopetrosis just affect a single bone in a single site?
Hemosystemic multisystem.
Think about one of your differentials you mentioned earlier. And remember, it probably took some delay because patients clinicians didn't want an urgent CT scan. They said, oh, do it when the next available. So you've got some time in between the MR and the CT, maybe a week or 2 weeks. 2 week wait, 2 week wait, so 2 weeks.
So there is a tract communicating from to the superficial. So this could be osteomyelitis.
Okay. So fine, I see where your point. So I see where you're going with the. Let me just go back to with that. So I think we mentioned about the periosteal reaction here. Not much in the way of lytic or bony destruction or osteopenia. I mean, the bone densities look quite similar, apart from that periosteal reaction that we can see. So on MR, these are just, if I'm not wrong, these are actually just T2 stir sequences, fat suppressed sequences. There's no contrast here. This T1, so rightly pointed out, there is the area of marrow abnormality in there, which hypo or iso-intense on T1, hyperintense on T2, with probably a bit of periosteal inflammation medially. And you can see there a bit of soft tissue. But otherwise, no soft tissue mass, okay? And then on the CT, the same cortical thickening, and you've got this little area of lucency here. I see where you're coming from. You're thinking it's a tract, but if I say it was osteomyelitis, then you'd be expecting a bit more, I think, sclerosis and certainly some soft tissue changes, which we're not really seeing that florid on the MR. Also thinking of osteomyelitis, yes, I did say it was periosteal location, but often you would also get it. It will move somewhere. It often starts metaphyses, then going subperiosteal. I think that's the more common distribution than subperiosteal going inwards. And then if you correlate it on the CT coronal, where that's your nutrient vessel surrounded by that kind of corticated area bone, you've got to see a very fine lucency here. And this was thought to be a stress fracture. Okay, so certainly because of the initial appearance, this was discussed in the bone center unit, and given the patient's really well, this was considered a stress fracture. Now, the other thing was that, is this a stress fracture from an underlying pathology? So she had a whole body MR, and counting for the weight in between, all the that meridema had actually improved, and she had no other lesions elsewhere. So this was treated as a stress fracture. So stress fractures, in kids, you often see in the tibia, you think of shin splints, often the sports person. It's true, a femoral region is a slightly more rare one, but still can happen. And on X-ray, it can be quite subtle. I mean, I think you need to, all the other things you're thinking about, infection, even osteostoma, it's a very important differentials. And MR would help you to delineate the extent of in marrow involvement, and then if you're still in doubt, do a CT for characterization. I think in kids, if you don't find the answer with a single modality and you think that it could be certain other differentials, consider their CT. Although there's radiation, it can help you to narrow down your differentials. I'm not saying to do it in every one you don't have answer for MRI, but if you have an answer and you have a potential differentials, some of which can be excluded on CT, like osteoma, do it. Okay. Now, if we just talked about marrow signal changes, I think one of my ex-bosses used to tell me very good things. So if you just see marrow edema on MR without anything else, you think of three things. One is osteoma, which you can't see the nidus because the nidus is better seen on CT. You think of a stress fracture, and the third thing you think of is early infection. Okay. Right. Other examples of past, stress-related changes or stress-related injuries is past defect. Here, in kids, not always, you get the slippage or the listhesis, the enterolisthesis. You know why, because this thing sticks to here, and then you've got the two bits acting like hinges, so protecting this from slipping forward. When you've got the fracture there, if it's bilateral in particular, then you lose that little grip between the bone edges, so this whole thing slips forward. That's why I've got an enterolisthesis of the upper vertebrae on relative to the lower vertebrae. Okay, it can be chronic, it can be acute on chronic. Yeah, actually, yeah, it's usually it can be chronic or acute, and then your MRI, of course, if it's acute, you see more marrow edema, soft tissue changes, and if it's more chronic because something had happened and then things have changed, then you see less of the soft tissue inflammation surrounding it. So often you see in gymnasts or sports which needs a lot of hyperextension, like baseball throwing. Yeah, so past event. Okay, next case. This is a difficult case. So you can ask me questions, or I might give you hints. So we've got a series of studies. It's a story case, okay? So have a look at the first X-ray. Tell me what you see. Just tell me what you see, but don't give me a differential first. Then I'll show you other images.
This is frontal radiograph, frog-leg view of the pelvis. I can see that there is irregular loosened area in the right femoral neck in intertrochanteric region and proximal shaft. There is suggestion of some morphotopic appearance, suggestive of an aggressive pattern. There is no pathological break. There is no extraosseous soft tissue. So this could represent Ewing sarcoma or lymphoma.
Sorry, candidate 4. Are you looking at the left or the right?
The right.
The right hip. Is it right? Are you looking at the right hip?
Yes.
Okay. And are you talking about some abnormalities in this region here?
A little caudal to that, a little lower.
Lower, here.
Above. I think subtrochanteric region, yes.
Okay, okay. Okay, so you think there's a malignant process going on here, okay. What do you think of this?
There's a periosteal reaction, lamellated type of periosteal reaction in the visualized femur.
Okay. And then how about the left hip or the left leg?
This is the left leg. Okay, there's a fracture of the left femur, which is an old fracture because there are corticated margins along with the periosteal reaction, and there's evidence of a soft tissue around that. So okay. This could be a pathological fracture on the left side.
Okay. Anything else to add?
This is sparing the epiphysis involving the diaphysis predominantly.
Mm. Okay, don't worry. We'll go on to the next one.
So this is an ultrasound. So this is an MRI P1 coronal sagittal and axial showing a large T1 isointense mass lesion arising in the right renal right right paravertebral region with extension through the neural foramen. So this could represent a neuroblastoma
Good.
and
Okay. Yeah.
metastasis.
Okay. So this is just quick note. This is June 2019. Okay. So 1 year down the line. This is June 2018. So 1 year before, which is right. Patient is young. This was about 1 year of age with neuroblastoma. Okay. And then he was treated. This June, yeah, he was treated quite quickly, and then of course, and in May 2019, so 1 month before your initial X-ray, this is how his MRI spine looked like.
Sagittal MRI of the cervical spine and of the thoracolumbar spine. On the cervical spine, there's no intramedullary lesion within the spinal cord. The surrounding CSF spaces are fine.
Do you still see, I know I only give you the slides, but on the right hand side of the lumbar spine or lower spine, do you see that big lesion anymore? Patient has aggressive treatment. They've given him, I can't remember what they give to treat neuroblastomas, but essentially they gave him the all clear.
There is a residual small lesion seen in the mid-lumbar region.
Yeah, possibly this that you're looking at. Okay. So are you still going with pathological fractures? Sorry, it's a difficult case. Essentially, what I was just trying to show you was on the line of insufficient fractures. I mean, I like the fact that you thought, so let's go back to what you said. There is no metaphyseal lesion here. Yes, there's a little bit of irregularity here. I just wonder whether it's due to his position or whether this could be some sort of heterotopic ossification from some of the cause. But metaphysis is clean, your epiphysis is clean. I think the diaphysis is probably a bit projectional because you can see it, he's not quite centered, it's a bit rotated. He has periosteal reaction on the right side, and it's confirmed on the long leg views. And on the left side, yes, it's probably a more chronic fracture with periosteal reaction and signs of healing. It's undisplaced. It's displaced and quite separate from each other, which is why it's probably trying to heal but cannot heal. You can see all that soft tissue edema and soft tissue swelling because of the density of the soft tissues. Okay, so something's going on wrong here. So the reason why I've showed you this, because this is actually a type of insufficiency fracture. Now, you wouldn't be able to tell it from the first instance. All you can say is that there is a displaced fracture on the left and periosteal reaction suggestive of a fracture, but an underlying soft tissue, a bony process, malignancy cannot be excluded. Do an MRI to characterize, but I think on the other view, which I may not have shown, there was a cortical fracture with evidence of healing. So this just shows you that when you see neuroblastoma, first thing you think of is bone mets causing pathological fracture. But I think the next image that I show you is that patient's been treated. You see, this is your cord. The cord's essentially because of radiotherapy. I think the guy had radiotherapy. You've got long-standing, Malaysic changes. So patient's actually paraplegic, okay, because of the treatment. And subsequent to that, he's developed disuse osteopenia, and that those are actually insufficiency rather than pathological fractures. But pathological fractures, given the history, would also be reasonable. Okay, so we know the difference between insufficiency, so it's physiologic stress on abnormal bone in this case, so osteopenia, disuse. And according to Wolff's law, your bone's constantly remodeling. So if you give it stresses, then it will continue to lay down new bone and become stronger. And if you don't use it, it will start to waste away. A stress fracture is one that we saw earlier. So it's abnormal stress, like overworking it on otherwise normal bone. You're not giving the bone and microtrabecular changes time to heal. And I always leave pathological fracture for something that's weakened by tumor, so like a metastasis, pathological fracture. You can argue, some of the bone tumors that Dr. Kapoor had mentioned earlier. If there was a fracture, you can still call it pathological because there is a tumor process within there. So many causes. This is more from the adult population. You can get insufficient fractures from lots of things. I think in kids, you are thinking more of the previously irradiated bone because, radiotherapy is quite common in the pediatric cancers. Okay, next case. So I will give you a history. While running, fell over and twisted ankle.
So frontal and lateral radiograph of the ankle joint. The fibula and tibia are seen. They are both normal. The talus is fine. The rest of the carpal bones, the phalanges are fine. Looking at the calcaneum, on the superior aspect of the calcaneum, okay, no, that's unfused apophysis. I cannot see any fracture or dislocation on this view.
So painful swollen ankle.
There is some soft tissue swelling around the ankle joint.
Any joint effusions?
Oh, yes, there is some soft tissue swelling, could be a joint effusion. I would suggest an MRI for the evaluation.
Yeah. So I think it's a point just to make that just when you're reporting pediatric films, just take a close look at drawing all the contours. So, and anything, any lucencies, you should be able to define it. And if you can't, look at Keats first to make sure it's not a normal variant, and then after that you can explore the other different shows. So there is soft tissue swelling, okay. Certainly on the lateral aspect, maybe you can say a little bit on the medial, just cause it, to my eye, they look a little bit more full than compared to normal or normal fat. But there's definitely more on the lateral side and medial side. So I usually took a kind of make an eyeball measurement of subjective. So this is quite small and this is big. So you say more on the lateral side. Same goes for joint effusion. So you're seeing bulging of the anterior capsule and bulging of the posterior capsule. So there's a large joint effusion. And then when you're looking at that, you're thinking of any intra-articular processes going on. It's trauma, so I won't be thinking of JIA. But if you look again closely, you're drawing contours. If you come down metaphyses and suddenly you've got a little step here, okay? And then you wonder, yes, I know physis can be irregular in the distal tibia, but I just wondered if there was just a little bit odd in the front bit here. And then if I take a look again, thinking, okay, is this a fracture? There is a lucency that's just behind this at the tibia of epiphysis. And if I give an additional history that the child is probably 14 or 15, a boy, or 12 to 13 when you're a girl, and that's when your epiphysis starts to close, then you're thinking of ankle fractures that's specific to the closing epiphysis, okay? And you can see here it's a little bit wider on the lateral side and a bit more fused on the medial side. So this is a tilo fracture. So this is very similar to what the triplane fracture, but these are ones that only occurs in the closing physis. So it's an intra-articular fracture through the epiphysis and then along the physis, okay? They can be hard to spot and easy to miss. So if something doesn't add up, you go back to clinicians and say low yield for MRI, like you rightly mentioned. But of course, if you can see it on the X-ray and they just want to know how to manage it surgically, then sometimes they ask for CT for better characterization. So ankle abduction, external rotation, that's a mechanism that's quite similar for a lot of the other ankle injuries that you get in adults. It's often that. And then depending on whether it's internal external rotation, you get the medial bands of ligaments or lateral band of ligaments injuries to that. So as I mentioned earlier, there's a fracture pattern. It's vertical fracture through the distal epiphysis and then through the lateral physis, a horizontal component, and this off the ankle. So tilo fractures off the ankle. So metaphyses, so knowing how the metaphyses closes is important. So this is why a lot of it goes through the fracture line, goes through the open physis, so laterally, because it starts centrally, then it goes medially, the closure, and then finally the lateral physis closure, hence accounting for the pattern of injury. So I'm not going to let you go through this case because I think I've already mentioned it earlier. So this is the other slightly more extreme version where you've got that nice line through, and then through the opening of the lateral unfused physis, you can say, central is definitely closed, medial may be closing because there's a bit of lucencies here and a bit more continuity here, and this opened, and then when you see on a slightly rotated view, you can see the fracture going up here. Okay, so this is a triplane fracture. Yeah, and said earlier, so CT helps with your characterization for surgical planning. Okay, we're going to a different type of lesions now. We're at the end, nearing the end. So candidate 4, do you want to have a guess what these are? So baby, it's an infant, less than 1 year old.
Of the foot of the knee joint, showing a large soft tissue mass lesion on the dorsal aspect of the dorsal aspect of the distal femur. The adjacent bone appears normal. It's quite far away from the bone. So this is a soft tissue mass for which an ultrasound is performed. The ultrasound is showing that it's heterogeneous, predominantly a hyperechoic area with increased vascularity. If it was compressible during the ultrasound, then this could be a hemangioma.
Okay. Another, well, same diagnosis, different case. And then after you kind of go through this, you tell me what you think. So what your conclusion is.
Okay, so this is a T2 weighted MRI coronal of the brain. The brain and CSF spaces are normal. There is a T2 hyperintense area in the left parotid, which is showing on ultrasound, which is well encapsulated and showing vascularity. Okay, there is an internal septa, so this could be a liposarcoma.
Okay, so I said this is the same diagnosis. So you've gone from possible hemangioma to liposarcoma. What do you think it is? So same diagnosis, just different cases. You're going with liposarcoma, or are you going with hemangioma?
I think hemangioma.
Yeah. Okay. So these are hemangiomas. So often they present. You can have congenital forms which present at birth, or you can have those that present a bit later in life. So this is purely soft tissue, like what candidate 4 mentioned, no bony involvement, and on ultrasound it can be quite a heterogeneous lesion, quite well circumscribed because hemangiomas are vascular tumors. Okay. They can be compressible, so sometimes they're not so compressible. The more compressible one tends to be vascular malformations, like veno-lymphatic malformations, where they've got more cystic spaces. And the key thing is that with hemangiomas, they're often very richly vascular.